as I told you, it depends on from where you approach the spine. If you're approaching bang on anteriorly, that is ALIF. If you're approaching anterior to the psoas, that is going to be OLIF. Through the psoas is XLIF. Posteriorly, PLIF and TLIF is something. If you're going through the foramen, that is TLIF. Bang on posterior is PLIF. So the objective is the same. You do a thorough decompression and you achieve a fusion. It depends on from where you're exactly approaching the spine. That makes a difference. MIS-TLIF, so minimally invasive TLIFs, we put in guide wires. This is how I do. I put in guide wires where the screws are going to be. Then I do the interbody and the disc wire, do a proper decompression. Then we put in the screws and the rods. And the best thing about MIS-TLIF is that via bending the table, we even do the over the top decompression and do the decompression on the contralateral side very easily as well. So this is how most commonly MIS-TLIF is being one of the major surgeries that is done regularly for such types of pathology. Now, LLIF is transpsoas corridor. Generally, LLIF is not suitable for L5S1 because there is a risk of the injury to the lumbar plexus and the psoas injuries can happen. So as you're seeing over here, whenever you're going through the psoas muscle, there is a high chance that you may develop the injury to the lumbar plexus or the psoas injury. OLIF, you go anterior to the psoas. ALIF, when you're going bang on anteriorly. ALIF, there are risks that are involved in regards to injury to the IVC, and in OLIF, the injury to the ureter, which are very dreadful complications. That is the reason why most commonly TLIF and MIS-TLIF is done rather than the ALIF or the OLIF. Now, when we compare ALIF and TLIF, dural injury is significantly lower in ALIF. Blood vessel injury is higher in ALIF. Radiologically, ALIF may be superior to TLIF. Significant indirect foraminal decompression, restoration of disc height and foraminal height is something that can be achieved via ALIF. PLIF versus TLIF, neurological deficit, graft position, durotomy would be higher maybe in PLIF. Clinical satisfaction, blood loss, nerve root injury, graft malposition, infection and radiological fusion are similar both in PLIF and TLIF cohorts. So, both would show more or less the same results. Why is TLIF more commonly done? Because you don't retract much of dura in that. PLIF requires some retraction of the dura. Hence, TLIF is generally more commonly preferred over PLIFs.